job, Becky. So our next speaker is Gary Hamilton. He is a clinical specialist for the Western region for ResMed, and he is here to talk to us on advanced positive airway pressure therapy. What device for what patient? So please welcome Gary.
Thank you. Can you all hear me? Okay, good. Just a quick background of myself. I've been with ResMed about 18 years. I've been a respiratory therapist probably about 40 years. And yes, it is true, I was 11 years old when I started. And I'll stick to that story. Actually, when I started, we were the IT department, inhalation therapy. And I wish I would have saved those name tags that said that, so I could say I worked IT now. But yeah, things have changed. And this will, out of curiosity, how many, if any, how many people here work in the sleep lab? Any? One? I see one. Okay, two? Okay. How many RTs or whatever in home care? Okay, so I'm assuming the rest in the hospital. Not sure what other choices there are. So, okay. This is slanted a lot, well, not a lot, some of it toward the sleep lab, and so that's why I want to make sure, so I'm not talking shop talk that you guys aren't sure about that. But again, any questions? Well, hopefully I'll zip through it quick. There's only about 130 slides. No, there's not. 110. No, there aren't. I'll try to zip through it quick so we have time for questions too at the end. In the beginning, I'm working for ResMed, so I get paid by them, hopefully, and have stock. So generally, I try to keep it pretty generic, but probably most of the pictures I have of the machines probably is ResMed. I think I have one Philips in here, but I have more access to ResMed stuff. So, and when we talk specifically about algorithms, I'll try to generalize them, but some of the things I know are more specific to the ResMed, but we'll deal with that when we come up to it. So basically, we're going to go, everybody, pretty familiar, probably familiar with CPAP, but certain patients, that may not be the best choice. Maybe you figure that out in the sleep lab, maybe you figure it out at home, maybe you see it in the hospital, these patients. But again, that's a key, figuring out, I don't think CPAP's going to work on this person. So knowing that, different uses of bilevel, because that'll be your next step. Let's go to a bilevel. What are the different uses and there's different types of bilevels. We'll talk about that. As we get more complicated, know when you would use a servo, which would be an ASV or VAPS mode. Why do they work? What's the algorithm, how the algorithm works, and a little bit about the VAPS too. We'll do some about reimbursement also, which in the hospital that may be a whole different world for you. Home care, you have to live that because you want to get paid, and then sleep lab has to deal with that too. So again, why patients fail CPAP. This one might be because it messes up his hair, but I'm not sure about that. But you'll hear all kinds of things. It's uncomfortable. I have to wear that every night. The higher pressures, even though all the machines now have pressure relief features on them, but still they may complain about high pressures. Knowing that, yeah, they may have OSA, but they got COPD also. That can be an issue because the CPAP may make them worse. They can't exhale now against it. And so knowing that, CPAP probably isn't going to be the best choice for those patients. Bilevel probably is going to be smarter. And they may have other diseases, neuromuscular. They may have ALS or something, or then a CPAP probably keeps the airway from collapsing, but they probably need help ventilating. So knowing that up front will lead you to believe, I don't think a CPAP's going to work on that. And you can pin it down if you're looking at someone going through a sleep study or looking at someone in the hospital. What they may have may differ. If we work here, did we just die? Actually, I don't think I want to log on here. See if that's the problem. There. If we have OSA, you have COPD, different people you might see through a sleep study or people that may need a machine. Might have neuromuscular, ALS, muscular dystrophy, different things. Kyphoscoliosis severe, that could be an option too. Cheyne-Stokes breathing, which may see more in the hospital, usually related to heart failure, but it could be brainstem trauma or something like that. Or complex with TEXA. We have too many initials, I'll tell you. That's treatment emergent complex sleep apnea. So those are some things that someone may see in the sleep lab studying these patients. You could see them in the hospital too. But as we pin down either all of them, OSA, that's an airway problem. They more or less lose muscle tone in the airway, it collapses, and they have sleep apnea. COPD, it's more of a ventilation problem. Or we used to say OSA is an upper airway problem, COPD is a lower airway problem. Usually if they're just COPD, they just don't breathe that well. They need assistance, especially at night when they sleep. Neuromuscular, again, same thing, different reason, but same thing, ventilation problem. Muscles are weak or the brain's not firing to actually ventilate, get the muscles to contract. Cheyne-Stokes is a ventilation problem, but the other way around. It's not that they hypoventilate, it means they blow their CO2 down. Many Cheyne-Stokes heart failure patients, if you did blood gases on them, their CO2s many times are just in the low side of normal. And so usually their problem is they're blowing their CO2 down so low, the brain says, quit breathing. And so then you have centrals. Now this treatment emergent complex sleep apnea, that's kind of both. Their airways may collapse, plus they also blow their CO2 down, so they have centrals. So it's kind of both. So knowing, got this disease, this is an airway problem, CPAP probably would work. But this is a ventilation problem. CPAP's not going to ventilate someone, so you probably need to either do a bilevel or a ventilator, depending on how severe they are. So that helps knowing if you got a diagnosis, where would I go next? And I apologize for this slide, because like a lot of Medicare guidelines, it's kind of not that clear and kind of blurry, but that is the Medicare guidelines to get qualified for a CPAP there. And only because I'm old and I remember, when I went into home care, CPAP wasn't that, it was just getting going. It was invented in 81. I went into home care in 85, and we were just starting to see CPAPs, and they didn't look like they do now. I know the first machine I saw was called a silent giant. The giant part was right. The silent, I'm thinking it was manufactured at a deaf college or something, because it was about like a weed whacker you would hear, and patients slept through it. But the guidelines at that time, Medicare said you had to have 30 apneas over, I think, a 6-hour period or something like that. When a lot of these patients don't have apneas, they have hypopneas. And so it was really hard to get those patients covered, and sometimes. And I think we had Blue Cross that actually said you had to desat also. A few years later, they changed the guidelines to basically you can almost get anyone covered, meaning AHI, if an AHI, apnea-hypopnea index, below 5, that's what's considered normal. They're saying, if you have 15, AHI 15, I'll cover you for CPAP. But if you have 5 to 14, give me another diagnosis, and we'll cover it, like daytime sleepiness, some other things in there, impaired cognition, mood disorders. So basically, they went from really hard to get covered to basically you could get almost anybody covered, probably. So they really opened the gates to realize this was a problem, let's get that covered. And so those are the guidelines now. So with the diagnosis of OSA, you go to a CPAP. They added some more guidelines a few years later in the sense of only to go to a bilevel, they added some guidelines in the sense of, and that's what this is talking about, this guy's not doing well on a CPAP. So let's go to a bilevel. They say, well, document some things. It's somewhat common sense in the sense of they're saying, hey, this patient's not doing well, and it's not a mask problem. The guy has appropriate mask that fits, so it's not a mask problem, so you document that, and you say, hey, we tried to do other things. We lowered the pressure. We tried pressure relief features, and anything we do, they don't sleep that well. It doesn't control the symptoms of OSA. The HI is still high. Kind of common sense. They just wanted this now documented in the physician notes. So if you go from a CPAP to a bilevel, again, it's more money. The CPAP, well, I'm afraid to bring up how much it is now. It used to be, the old days, it was about, Medicare paid about $110 a month, and I want to say it's close to $50 now, times 13 months. and the bilevel used to be twice as much, and maybe it is, but you got to jump through more hoops to get to a bilevel. But if you have a diagnosis of just OSA, it's not that hard. It's kind of common sense. They're not doing well. Why? Well, just document this stuff. You can go to a bilevel. If they're in the sleep lab or once they go home, you can do that too. So with a diagnosis of OSA, that's not that hard. Now you can, here's the little things that you have to do in the months. You have to prove compliance within the first 90 days. The smart thing is if you're going, you think this patient needs a bilevel, it's smarter to get that figured out in the first 30 days. Because if it drags on a little bit more to, about the 3 months, and you wait to do it there, you have to do more hoops. You got to jump through more hoops. If it's past that, you have to do another sleep study. But if it's in there, you have to have another face-to-face with the physicians. So there are these little hoops to jump through. But the bottom line, if you think you're going to have to go to a bilevel, it's smart to do it in this first 30 days. And the nice thing about the old days is you didn't get a whole lot in the downloads. Now the machines are so smart and they have so much data. Before, we might go out and download it, get the machine and download it every 30 days, and you'd see maybe, did they use it, and maybe a leak, but you didn't really get apnea hypopneas a long time ago. Now you get it like everything. And I used to have patients that would try to put a potato on the end of the mask and try to fool it, and had to explain to them there's breath detection it's looking for, so you can't do that. Actually, one of the first patients we set up on an auto, I remember she called in and said, hey, can you come pick up my machine? I'm done with it. I go, well, let me call the doctor and get a DC, discharge order, for that, and then we'll come out and download it. She goes, what do you mean download it? Well, we'll see how much you used it and how you did. Oh, can you come back next month? So then a little light clicked on our brains to say, hey, we need to tell them we can see if they're using it now. And now, granted, now we just log on the internet, on the website, and actually see if they're using it. We can change settings that way. That's what's changed hugely in the sense of you'll know if this patient's using it, you'll know if it's adequate therapy, and then you can actually address it. And it's just smarter to do it in this first 30 days because you're going to go down. You'll be able to flip them to a better machine that'll be more appropriate for them a lot quicker instead of jumping through more hoops. And we're pretty sure, I don't think I'm going out on a huge limb now, pretty sure Medicare isn't going to start going, we need to pay you more for that stuff. Pretty sure it's going the other way. So as a manufacturer, our goal is to make it more efficient. What costs the most about providing CPAP? It's probably not the cost of the machine, it's the labor involved, hopefully a therapist involved. If we can make that a lot more economical, you can sit in the office to find these patients and see what they're doing. That's a lot smarter, and then you can actually survive on the reimbursement. So that's with an OSA diagnosis. If you throw another diagnosis, so they don't have OSA, they have COPD. Now you get thrown into these respiratory assist device guidelines, RADs. And each one, it's all by diagnosis. One of the easiest ones probably is this restrictive, which is also neuromuscular. So in fact, if you have, say, ALS, neuromuscular, you don't even have to do a sleep study, you can do a pulmonary functions. Forced vital capacity or an MIP, and then you have to rule out COPD. They write a note, and you can go to a bilevel without a backup rate or with a backup rate. That's probably the easiest one. Or you can do a blood gas and an oximetry. So that's not that hard with that diagnosis to get covered. That's easy. Then you go COPD. You could set up a COPD on a bilevel without a backup rate, without a sleep study. You just got to show their CO2 is greater, 52 or greater. They desat for 5 minutes, 88 or below, for total 5 minutes, minimum 2 hours, either on 2 liters a minute or whatever they're wearing at home, whatever's greater. And then OSA and CPAP has been considered, but the doctor just writes it's not because of that's not the reason for their hypoventilation or not the reason for their oxygenation or lack of, and then you can get a bilevel without a backup rate. Now, if you want to get a backup rate, which is a 471, you have to jump through more hoops. It's almost like you have to have a note from God, and many times they'll deny that too. So it's real difficult in that. But to go to a bilevel, just without a backup rate, not that hard with that diagnosis, assuming their CO2's up there. Other one, another one, central apnea, which as long as you meet this criteria, this is Medicare's definition of central sleep apnea. And the big one here is this, of all the apneas, hypopneas. Put them together, more than 50% of them are centrals, then that's the big E to classify, yeah, this is a central apnea patient. And then you can go through this little hoops, which is not, if you meet those, that's not hard, and then